So now when we talk about lung maturity, we want to promote fetal lung maturity, and we talk about glucocorticoids that are given. It's given IM. It's actually given to the mother because the baby has not been born yet. We are promoting fetal lung maturity. It's one of the reasons why they give tocolytics to stop or put on hold the uterine contractions in the process of labor so that we can get the betamethasone into mom and promote the fetal lung maturity. It's given between 24 and 34 weeks gestation. Usually the benefits occur within the first 24 hours after that is given. Some of the things that's shown to reduce is respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. So now we're going to talk about a couple of other terms, and you're going to see them written PROM. This is premature rupture of membranes. This is where you actually have the spontaneous rupture of the amniotic sac. It leaks amniotic fluid beginning before the onset of labor at any gestational age. If you have a preterm premature rupture of membranes, you will see PPROM. This is where the membranes rupture before the completion of 37 weeks. So just think of preterm infants, preterm labor, preterm birth, preterm premature rupture of membranes, same classification as far as weeks go. The other thing we want to talk about is chorioamnitis. This is actually pretty common maternal complication of preterm premature rupture of membranes. We actually, I think, talk about it a little later, but let me flip to that, and while we're on it, we'll go ahead and talk about chorioamnitis. So chorioamnitis starts on page 452. It's a bacterial infection of the amniotic cavity. Complications are not only for mom, but for baby, and this is complications at any gestational age. What will happen? What will mom present with? She's going to present with a fever. She's going to have tachycardia. Baby's going to be tachycardic on the monitor. She's going to have uterine tenderness, and she's going to have stinky, foul odor to her amniotic fluid because she's going to probably be leaking it or seeping it a little bit. This occurs when the membranes are ruptured, or can occur when labor begins. We have to think about there's organisms that are part of that normal vaginal flora. They end up in that amniotic cavity. Some of the reasons that happens: a long labor, a prolonged membrane rupture, too many multiple vaginal exams. They may have used an internal fetal monitor where they actually put it into the baby where they're monitoring the fetal heart rate, so it's called internal. And what are some other risk factors? Young maternal age, low socioeconomic status, urinary pre-existing infections of the lower genital tract. So what we want to watch out for, why do we want to prevent, why do we want to take care of these moms with the chorioamnitis? Because they can develop bacteremia later. Baby can end up with pneumonia, bacteremia, and sepsis. And let me tell you, sepsis in a neonate is fatal because they get sick quick. How can we treat it? How do we prevent the complications? We want to give them broad spectrum antibiotics. We want to deliver the baby. So some of the antibiotics that can be given are your ampicillin or penicillin and gentamicin. They usually are given those particular antibiotics during labor. If mom has to have a C-section, they will usually add on an anaerobic organism type antibiotic, and that's going to be your Cleocin and Flagyl. Usually the antibiotics are discontinued after the birth of the baby. They may so that kind of goes over your chorioamnitis just a little bit. I'm just going to back up just a short distance because we were talking about premature rupture of membranes. One of the things that will be done if mom has premature rupture of membranes is they're going to assess baby. We always need to assess baby's well-being. And remember, the way to do that is a non-stress test and a BPP. We want to know how baby's doing. Mom can also do her daily kick counts. We're going to monitor for signs and symptoms of labor. We want to monitor for placental abruption or any kind of intrauterine infection. We have already talked about giving the glucocorticoids to mom in order to promote fetal lung development. Moms can also be given, for premature rupture of membranes, antibiotics. Ampicillin, erythromycin is usually what they will give. What happens with the antibiotics? Why do we give it? This prolongs the time between the rupture of the membrane and birth, so we decrease the risk of chorioamnitis. So now we need to talk about postterm. Postterm is defined as the pregnancy that extends beyond 42 weeks. What are some of the risk factors? Dysfunctional labor, perineal injury for mom, because we have these little macrosomic babies. And when we talk about macrosomia, we now have a gram of weight put on it, and they are 4,000 grams, which makes them a 0.8 pound baby. So that is what we consider macrosomia. So what are some other things that can happen? Maternal risk, hemorrhage, infection. A lot of times these moms have to be induced for labor. They may use the prostaglandins or oxytocin. These moms may have to have forceps or a vacuum-assisted birth. And I will bring to class forceps in a vacuum so you guys can see that. What are some other complications that are associated with the postterm pregnancy? Abnormal fetal growth. So there is a risk for having a small for gestational age baby because the babies actually are undernourished. Because remember, the longer we go past 40 weeks, the less efficient the placenta is in its job. But for the most part, you have macrosomia greater than 4,000 grams or 8.8 pounds. The other thing when we talk about, remember, the placenta ages. So the placenta gets old. The placenta has an increase in calcium deposits in fibrin. So this causes the placenta to actually not be able to oxygenate the baby. Usually there's also a decrease in the amniotic fluid. What happens then? What happens if we have this nice little donut and this little baby's in the donut and we have all this fluid around making the baby nice and squishy, protecting the baby, and that fluid starts to diminish? Then we don't have this nice little swimming pool, so the baby becomes at risk for a cord compression. And when I'm talking about a cord compression, that means the umbilical cord could possibly wrap around the body, the neck, which they'll call a nuchal cord, and we don't want that to happen because that's going to restrict airway. So how are we going to assess? These are going to be the moms who have a BPP or NST done. They may also have their amniotic fluid volume measured because we want to know how baby's doing in there. If mom does have low amniotic fluid, they can do something called an amnio infusion. This is where they're actually restoring the amniotic fluid, or restoring volume, not amniotic fluid. They're actually restoring fluid volume back into the space. We'll talk about that when we talk about chapter 15. It talks about amnio infusions. We're going to talk about dysfunctional labor or dystocia. So this is a long, difficult, or an abnormal labor. It's associated with 5 different factors. Those factors are on page 453 in your textbook. One of those are ineffective uterine contractions or the maternal bearing down efforts. Remember, that's considered the powers. Remember the 5 P's? Everything starts to come back around into play, kind of repetitious. One of the other things that can cause dystocia is alterations in the actual pelvic structure. That's the passage or passageway. The other thing is fetal causes. The baby's actually got an abnormal presentation or position. Baby has an excess size, so we have our little macrosomic baby. Or also number of fetuses. We have multiples in there. This is the passenger. And then we have actually the maternal position during labor and birth could be causing or disrupting, causing dystocia. Psychological responses, just actually of the mother, laboring in general. It may be influenced by her past experiences. Preparation, could be culture, could be support system. So these are a few factors that play into dysfunctional labor, or otherwise known as dystocia. So who's at a higher risk for having dysfunctional labor? Overweight, short stature, advanced maternal age, and remember we consider that 35. Infertility difficulties, and uterine abnormalities will play into this. There's some others that are listed. You can also have a uterus that's overstimulated with oxytocin, which will play an important role in having a dysfunctional labor. Sometimes it's just maternal fatigue and exhaustion. Moms come in, they don't just have this quick labor and bam, we got a baby. This goes on for hours, so they become very exhausted, electrolytes imbalance, because they can't have anything to eat and drink during this process. So those are some of the factors that would play into that. So we're going to talk about a couple things: hypertonic uterine dysfunction and hypotonic. Hypertonic is usually in the first stage, latent phase, whereas hypotonic is usually first stage, active. So with first stage latent phase, what's happening? Usually the contractions are kind of uncoordinated. The contractions may be in the midsection of the uterus rather than at the fundus. So the uterus then cannot apply that downward pressure to push the presenting part into the actual, against the cervix. So then the uterus cannot relax between contractions. Mom becomes exhausted, she becomes frustrated because there's lack of control and lack of progress in labor. So what do we want to do? Therapeutic rest. We can see if she can have a warm bath or a shower, maybe give some morphine to inhibit the uterine contractions, to allow her to rest and to decrease pain. The other thing is, if she's not having any pain, she could have Ambien to help her sleep. So when we talk about hypotonic, it's first stage active phase. This is where the contractions become weak, insufficient, or they stop. So contractions, weak, insufficient, and the other thing that you will assess is the uterus is indented. the uterus, and this is at the peak of the contraction. At the peak of the contraction, the uterus is usually nice and firm. So it's kind of got a hold or a halt on the progress of labor. Usually the reasons for this is CPD, cephalopelvic disproportion, or a malposition. And when I'm talking about malposition, I mean of baby. Baby is not in the correct position. So we need to make sure that they rule out CPD before they go any further. They can also assess the amniotic fluid, and we want to continue to assess mom. Let me write a few things back up here for hypertonic. It's uncoordinated. Oops. Not uncontrolled, uncoordinated. Uncoordinated, it's felt in the midsection of the uterus instead of fundus. Remember, fundus is the top of the uterus. This is causing a disruption in applying pressure. So now we're going to talk about, or your chapter brings us to CPD, which is your cephalopelvic disproportion. It's on page 457. So it's defined as there's an actual disproportion between the size of the baby and the size of mom's pelvis. So the baby is not able to fit through the pelvis and be born vaginally. These babies, once they determine that is definitely CPD, mom has to go and have a C-section. There's nothing else that can be done. Then we have something called malposition. When we talk about malposition, this goes back to when we're talking about that 3-letter acronym, where if you have ROP, you have right occipital posterior or posterior. So that's what I'm talking about, a malposition, or visually that's what we're looking at. So the common fetal malposition is persistent occipital posterior position. So what does that mean? That means the malpositions are the left OP and the right OP. Then we have malpresentation. This just means that the fetal presentation is something other than cephalic, and they like to say cephalic. What does that mean? That means that the head is down first. We want the head to be down first when the baby is being delivered. So the most common malpresentations are breech babies, and that's what you're looking at on your actual screen. Picture A is a frank breech. Picture B is a complete breech. Everything is turned around. So complete for picture B. And C is what they consider a single footling breech. So when they talk about frank breech, they define it as hips are flexed, knees are extended, and you can see this baby's got the toes up to the sky. Where a complete breech, they're all flexed in, but we're talking about butt being down.